Hello, everyone. This is Chadi Alraies coming to you from RSH 2026. I'm really privileged to be with Dr Aref Bin Abdulhak to talk about a very complex and planning for a complex structural intervention. Aref, thanks for being with us.
I'm glad to be with you, Shadi.
Thank you.
Thank you for having me.
So, right now, the simple cases come for low-risk, but also as structuralists, you have been seeing more complex cases coming towards you. So, can you tell us about how do you plan for these cases?
Thank you. It's a very good question about the planning. It's extremely important that as an intervention structural cardiologist, you know the wire skill and the technique, but you have to have an advanced also skill set to analyze the imaging. Like I am presenting two cases today. One of them with an interventricular septal aneurysm, critical AS, and severe LV dysfunction in a very sick patient
Mm.
that when needed a lot of advanced imaging. Of course, any TAVR will need a CT scan. Then you have to know what's in out of that CT scan, and that gonna help you planning your case.
Right.
Then even after the CT scan for the patient with the interventricular aneurysm, we were not sure is the interventricular aneurysm is actually an aneurysm of the interventricular septum or it was an aneurysm of the sinus of Valsalva.
Oh, okay.
Then we have to do an aortogram, and still the question was not clear.
Mm.
Then eventually we have to do a TEE. So from among three modality imaging, we eventually diagnosed it as an interventricular septal aneurysm.
Okay, so now you already planned for the procedure, looked at it, and you presented complex cases. So now you bring that back to the structural heart team.
Right.
So is there cases where you think the surgeon could have been more involved and should take the cases, or still going to go back to you to give him the transcatheter therapy?
That's a good question. Our surgeons are very involved in the planning. So we see the patient most of the time with them with the surgeon, and we discuss the patient in a multidisciplinary team meeting, including the surgeon and including an advanced imager cardiologist. Then in this particular case, it was not really clear, but after we did the almost two or three advanced imaging, we knew it's an interventricular septal aneurysm, and with a sick patient with a sick ventricle with a critical AS, then we brought it back to the heart team, including the surgeon. Uh, should we proceed with a high risk complex TAVR in this particular patient, or should the surgeon take him to the OR? And in fact, the surgeon deemed him again as a high risk, even in the presence of an interventricular septal aneurysm, and he was very sick. So he would not survive this hospital stay with a critically severe of the dysfunction. Then we decided to do a complex high risk
Yeah.
TAVR.
I just want to go to one question is about the high risk low coronary height, and which valve you prefer, self expanding or balloon expanding, and any backup technique.
That's a good question. It depends if it's a native valve or a bioprosthetic valve already in place. Generally speaking, if low coronary height, I would prefer the balloon expandable valve for future planning for ease of coronary access. And if there is any risk of coronary occlusion, even with the S3, um, I would prefer leaflet modification technique. And we have two or three technique already, and in fact, one device is available. But my my go to technique to decrease the risk of coronary obstruction now is the unicorn procedure.
Right. And in terms of backups, would you like Shimini or any plan for the procedure in terms of low left main intervention or low vein?
Again, it depends on the CT analysis. The sinuses are wider, and I don't think it's at significant risk of obstruction. I might implant the valve without coronary protection.
Right.
But if the sinuses are small, especially in the presence of the bioprosthetic valve, surgical valve, we may do the unicorn and or maybe the basilica or whatever other leaflet modification technique. And if you are still in concern about either left vein or the right, you may put a guide wire in there and
Okay.
the balloon or either stent, and if it's occluded, you just bail it out
Yeah.
and stent it.
Last comment is about 3D printing. We know it a few years ago was like a big thing for planning procedure. Is it still kind of used in current practice?
I'm not using it too much. You may use it in a very specific example. Only time I use it in the last year or two when I have a very difficult left atrial appendage in the presence of a device that's there, but there's a presence of significant leak around the device. Then
Got it.
I ask our imager to do a 3D printing, and it was a little bit helpful. But I know it was a fashion like a few years ago. I did not find it helpful like in a routine day to day
Right.
practice, but in a very specific example, it might be helpful.
All right. Well, Arif, thanks again for your insightful interview and for dealing with these complex cases that come towards you as structural interventions. Watch these videos and others on the YouTube channel. This is Chadi Alraies coming to you from Riyadh Structural Heart 2026. Arif, thanks again.